Hello everyone. Today we have another very high yield vignette for which is applicable for all the USMLE steps. So let's start with it. A 24-year-old boy is brought to the emergency department after collapsing while running a marathon. He has no significant past medical history. Family history reveals that his father died suddenly at age 32. On arrival, the temperature is 37.1, which is normal. Blood pressure is 100 over 70, which is normal. Heart rate is 160 per minute and it is irregular. So this is not normal. Heart rate is high. Patient is having tachycardia. Physical examination shows that the systolic murmur increases upon standing and with Valsalva maneuver, and it decreases with squatting. So this is another pertinent finding. So the murmurs that change upon different maneuvers, we call them dynamic murmurs because they change according to different circumstances, depending on how much blood flow there is through the different heart chambers. So this is a dynamic murmur. And the ECG shows that this is a wide complex tachycardia. Now, which of the following is the most likely underlying cause of this patient's presentation? Option A, anomalous origin of the left coronary artery from the pulmonary artery. Option B, dilated cardiomyopathy due to viral myocarditis. Option C, Wolff-Parkinson-White syndrome. Option D, aortic stenosis due to bicuspid aortic valve. And option E is hypertrophic cardiomyopathy. So now I've highlighted certain pertinent aspects of this vignette. We should always make it a point to focus on the important aspects of a vignette in order to arrive at the correct answer. Because the vignettes in USMLE exams tend to be particularly long, it is very rare that a vignette could be short. So, which is why we need to make it a habit to always make a mental map of the important things that might be present in a vignette in order to arrive at the correct answer. So here in this vignette, it is important to note that the patient is 24-year-old and it's a boy. Quite young for a patient to have certain heart issues, right? So there are only certain things that we can think of when a patient like this, a young boy, is presenting to the emergency room with a heart issue. And then the patient collapsed while running a marathon, right? So it was during a physical activity, during a sporting activity, that the patient experienced certain collapse. And then the patient's father died suddenly at age 32, right? Quite young for someone to die at the age of 32. That is also an important clue. Patient's heart rate was 160 per minute and it was irregular. Also something, something to be noted. And then there is a systolic murmur that increases with standing and Valsalva, decreases with squatting. This is a very important aspect and a very important learning point for you as well. This is a systolic murmur to begin with, which means the murmur is happening when the blood is exiting the heart. And then the intensity of the murmur is increasing when the patient is standing, and it is decreasing when the patient is squatting. And the intensity of the murmur is further increasing with Valsalva maneuver. So think of it this way. When the patient is standing and when the patient is undergoing Valsalva maneuver, or Valsalva maneuver is nothing but increased pressure in the abdomen and the chest, amount of blood is low in the heart, both while standing and during Valsalva maneuvers. So the intensity of this murmur is increasing while the blood is exiting the heart, and it is increasing when the amount of blood is low. In other words, when there is a lot of blood exiting the heart, the murmur is not as intense. But when there is a little bit of blood that is exiting the heart, the intensity is high. Okay, and then decreasing while squatting, because when the patient is squatting, there is increased return of blood to the heart, and when this increased blood is exiting the heart, the intensity of murmur is decreasing. So this should give us some clues as to what might be happening inside the heart, pointing us to the correct answer in the options. And the ECG shows wide complex tachycardia, and this also narrows down your differential diagnosis a lot. There are only certain wide complex tachycardias, right? So that is why this becomes a pertinent point here as well. So let's go through the options one by one now. Option A is anomalous origin of the left coronary artery from the pulmonary artery. I'm sorry, my video is blocking a little bit of the option there. Okay, so this is a long option, so let us break it down a little by little. So the left coronary artery is something that supplies blood to the left side of the heart, And pulmonary artery is an artery, a big artery that takes blood away from the heart into the lungs for oxygenation. In certain congenital anomalies, the left coronary artery arises from the pulmonary artery. Now, pulmonary artery, when the baby is still not born, is a very high pressure system because there is fluid filled in the lungs, and because of this, the pulmonary artery is not really taking blood to the lungs. In babies, they receive oxygenated blood already from the placenta, and because of which there is no function of the pulmonary artery taking blood to the lungs for oxygenation. So when the baby is still not born, because of the high pressure inside the pulmonary artery, blood is definitely pushed towards the left side of the heart. The heart muscle still receives blood, although it is not properly oxygenated, it still receives blood. But once the baby is born, and now the pressure inside the lungs drop, we also call this vascular resistance of the pulmonary artery. The vascular resistance of the pulmonary artery drops when the baby is born and the lungs open up for circulation. So when this happens, suddenly all of the blood from the pulmonary artery is going directly to the lungs. So from heart to the lungs, instead of it being a high pressure system, the pressure suddenly drops. Now because of this, left side of the heart doesn't receive blood from the pulmonary artery like it used to. So now the baby's left side of the heart suffers because of low blood supply, and then the patient starts experiencing symptoms such as irritability, poor feeding, failure to thrive, and the EKG might show something similar to a myocardial infarction in a newborn baby. Right? So obviously this option is wrong. This is included here because some students might think, oh wait, young patient is experiencing some heart issues, maybe this is something congenital, but this is not the case. This is a wrong option. So since option A is wrong, now let's move on to option B, dilated cardiomyopathy due to viral myocarditis. What is dilated cardiomyopathy? It's a systolic failure. So what does that mean? Systolic failure means that the systole is not happening properly. The heart is not able to pump blood effectively during systole. Why does it happen? Because there is dilation of the heart muscle. It is similar to a balloon being excessively dilated to a point where it loses its elasticity. Now it loses the wall strength, right? So now there is dilated cardiomyopathy because of viral myocarditis. Whenever there is a viral infection, there it can lead to a complication named viral myocarditis, where the immune system mistakes the heart muscle for certain um, viral particles and starts attacking the muscle. Because of this, the muscle undergoes a lot of damage, and because of this, it loses its elasticity and it undergoes certain changes resulting in dilated cardiomyopathy. Now, post-viral myocyte injury causes a globally dilated systolic left ventricular dysfunction, and this presents with dilated cardiomyopathy. The signs of dilated cardiomyopathy are very similar to any other heart failure. So there will be dyspnea, there will be orthopnea, edema, there will be S3 heart sound heard on auscultation, there can be functional mitral regurgitation and certain ventricular arrhythmias. A lot of these, which are very typical of heart failure, can happen in the patient. So since it is a young patient who collapsed, certain students might be tempted to think that this is the right answer. Maybe the patient had a viral infection and we missed it. That is wrong. Generally, a viral prodrome is mentioned in the vignette if that is what they want you to think about. Here, nothing of that sort was mentioned, and we don't see any symptoms of heart failure in this patient, and that is why this option is also wrong. So, when would this be right? If the patient experienced a recent viral infection and now after a week or two the patient is experiencing symptoms of heart failure such as difficulty in breathing, there is fatigue, there is S3 heart sound which indicates systolic failure heard on the auscultation, there is mitral regurgitation noted, and then there is cardiomegaly noted on the chest x-ray, all typical signs and symptoms of heart failure after a viral infection. So that is not what we see in our patient, so this is wrong. Moving on to option C, Wolff-Parkinson-White syndrome. What is Wolff-Parkinson-White syndrome? It is also a condition that can happen in young patients, and it can present with irregular wide complex tachycardia, which might tempt us to think that this might be a right answer, but it is not. So what is Wolff-Parkinson-White syndrome? It is a syndrome where there is an accessory pathway named bundle of Kent that is existing in certain patients. Uh, so accessory pathways can be a part of the fibers that carry electrical impulses from atria to ventricles. So bundle of Kent is an accessory pathway that can cause pre-excitation. What is this? So when electrical impulse, which is what we need for the contraction of heart muscles, moves from atria to ventricles in a systematic manner, certain times these impulses can go back to the atria, causing an abnormal contraction back there. So this happens because of certain abnormal fibers that exist in the system, and bundle of Kent is one of them. So when this happens, what we see are short PR waves and then delta waves and wide QRS complexes that are typically seen in the EKG. Delta wave is a buzzword for Wolff-Parkinson-White syndrome. So if we see a delta wave in the EKG or a delta wave is mentioned, then we have to really think about Wolff-Parkinson-White syndrome. So because of pre-excitation, there is an irregular heartbeat, irregular contractions happening, and this can sometimes result in hemodynamic instability. Although it is an irregular, wide complex tachycardia, this is still a wrong option because Wolff-Parkinson-White syndrome is the arrhythmia caused here is not dynamic. The murmur caused here is not dynamic as well. So a family history of sudden death and exertional syncope also doesn't, strongly give us a clue regarding Wolff-Parkinson-White syndrome. When could this be right though? When the vignette emphasizes palpitations or episodes of supraventricular tachycardia, or when the EKG shows delta waves at baseline, meaning when the patient is not having any symptoms of abnormality, and we see delta waves in their EKG, or we see atrial fibrillation with irregular wide complex tachycardia, this comes into a differential as well. But none of these exist in our patient except for the wide complex irregular tachycardia. So this is a wrong answer. So we move on to the next option. Now we have option D, aortic stenosis due to bicuspid aortic valve. What is this? So it is a common congenital valve lesion that can cause aortic stenosis in young adults. Aortic stenosis typically occurs in older patients, typically 60 to 70, but it can happen in younger patients when there is a bicuspid aortic valve, which is a congenital defect. When this is present, when aortic stenosis is present, there is a harsh crescendo decrescendo murmur at the right upper sternal border, and this murmur radiates to the carotids and may have an ejection click if the valve is still not completely destroyed. Why is this option tempting here? Because it is a young person with exertional collapse, and a bicuspid aortic valve can cause aortic stenosis in a young person, and aortic stenosis can definitely lead to an exertional syncope. So that's why this option becomes important. The However, there is a very important aspect to note here. With aortic stenosis, the murmur typically decreases in intensity with Valsalva and with standing. So when there is lesser flow of blood in the heart, the intensity of the murmur caused because of aortic stenosis decreases. What is happening in our patient is completely opposite. The intensity of the murmur is increasing with Valsalva and standing. So when there is less blood flowing through the heart, the intensity of murmur is increasing in our patient. But in aortic stenosis, the opposite happens. Why? Because in aortic stenosis, the caliber of or the size through which the blood flows is smaller. So because it is a stenosed valve. So when a lot of blood is flowing through a small space, absolutely the intensity of it goes up. So it is very important and very high yield for you to remember that in aortic stenosis, the intensity of the murmur goes up when the amount of blood flowing through the aortic valve increases, either because of squatting down, or because of other maneuvers that can increase blood. When would this option be right? When patient presents with exertional chest pain or syncope, there is radiation of the murmur to the carotids, and then the murmur gets louder with squatting and softer with Valsalva or standing, right? So that is it. We'll move on to the next option now. So now we arrive at the final option, which is hypertrophic cardiomyopathy. This is a correct option, obviously, because all the others are wrong. All the buzzwords mentioned in this vignette hold very true for this. So it is a young boy who collapsed during exertion, and he has a family history of his father dying also at a similar young age. Uh, Patient has tachycardia, which is irregular, and then there is a wide complex tachycardia noted on the EKG. So there is systolic murmur that increases with standing and Valsalva, and it decreases with squatting. What is hypertrophic cardiomyopathy? It is an autosomal dominant condition that causes damage to sarcomere proteins such as beta myosin heavy chain. This results in asymmetric enlargement of the septum, that is between the right ventricle and the left ventricle. So because of this asymmetric enlargement, there is an outflow tract obstruction. So there is an extramuscular growth right at the point where blood exits from the aortic valve, and because of this, when there is a strong flow of blood through this area, the extra flap of muscle causing obstruction there is pushed away, causing reduction in the intensity of the murmur, which is what happens when the patient is squatting. So in contrast, when the patient is standing or undergoing Valsalva maneuver, the amount of blood going through this area reduces, and because of this, the blood is unable to push away the extra flap of muscle that is causing the outflow tract obstruction there. And whenever there is increased obstruction like this, meaning the low flow of blood is unable to clear the obstruction properly, the intensity of the murmur increases. So this is why this is the correct option here. Certain things to keep in mind are that we give beta blockers for patients with hypertrophic cardiomyopathy because we want their ventricles to fill up properly. Beta blockers will reduce the heart rate and ensure that there is sufficient filling of the ventricles so that during systole, when blood is pushed, the obstruction is cleared properly. Also, we avoid dehydration in these patients, we avoid nitrates, we avoid diuretics, and any medication that reduces afterload. We do all this because we want to keep the flow through the aortic valve as strong as possible in these patients so that the obstruction is never too strong. In certain high risk patients, we can use implantable cardiac defibrillator so that we prevent sudden cardiac death. If the risk is too high, unfortunately, we'll have to ask the patient to refrain from competitive sports. So that is all about the vignette, today's vignette. I hope we were able to discuss a lot of high yield points. I hope I was able to provide some value to you during this exam preparation. I wish you a wonderful day. Thank you.